Thank you, everyone. And we're going to get started. But before we get started, we're going to have some housekeeping. I did want to welcome everybody to our very first After Cannabis, Hemp, and Natural Psychedelics Committee webinar series. We are going to try to present this at least once or twice a month. And we will have various subject matter experts sharing their expertise on all aspects of these natural botanicals. So before we get started, I do want to make sure that I read the AFTA webinar disclaimer, which is the views and opinions expressed during the virtual event are those of the presenters and not necessarily of the Association of Food and Drug Officials. So participation in the virtual event does not necessarily constitute an endorsement of the speaker's views, products, or services. This virtual event cannot be used to train AI models. So I just wanted to make sure that I got all that housekeeping out of the way. And we will also, if you have any questions during the webinar, please make sure that you ask that in the Q&A function. We will have a live Q&A at the very end with Dr. Potter. And I will go ahead and I'm so excited to introduce Dr. Potter as our very first speaker. He will be speaking on the conditional access of psychedelics, power, and the fight to keep whole plant cannabis medicine in the public domain. So Dr. Potter is the founder and chief science officer of Bio Unbound. And Dr. Potter, I'm handing it off to you.
Great. Thank you, Twee. I'm going to start by saying that good afternoon to everybody, and thank you for being here. My name is Del Potter, and I want to begin by acknowledging the nature of the audience. Many of you in the AFDO work inside institutions that carry real responsibility, public health protection, enforcement, standard setting, and harm prevention, and I really respect that work. I received my PhD in 1980 through a joint program between the University of California, San Francisco Medical School, and the University of California, Berkeley's Department of Anthropology. And my work is focused on psychiatric anthropology, ethnopsychopharmacology, and neuropharmacology, essentially the interface between culture, brain chemistry, and altered states of consciousness. Let's see. I also completed clinical training at the San Francisco Psychoanalytic Institute. But over the course of my career, I've worked in academic settings, clinical settings, pharmaceutical development settings, large-scale cannabis manufacturing environments. I've designed analytical pipelines, product standardization systems, and formulation strategies. So I've worked on psychedelic drug development, novel development as well. So I understand both the science and the regulatory architecture. And that is precisely why I'm going to say what I'm about to say. The title of this talk is Conditional Access, Psychedelics, Power, and the Fight to Keep Whole Plant Cannabis Medicine in the Public Domain. And that phrase, conditional access, is the backbone of the next hour, because access to these substances has never been free in this country. It has always been conditional, and the only thing that changes is who sets the conditions. We're at a structural turning point. Cannabis is moving toward rescheduling. Psychedelic-assisted therapy is moving into the medical mainstream. Capital is accelerating into both sectors. Universities are opening research centers, and pharmaceutical companies are filing regulatory pathways. From a regulatory standpoint, this is exactly the moment when the architecture of the field begins to harden. And once the architecture hardens, it becomes very difficult to reverse. Today's talk is not simply about cannabis or psychedelics. It's about what happens when an informal, culturally embedded medicine or drug ecosystem begins to translate into institutional medicine. Because translation is never neutral. Translation changes power. Translation changes who controls access, and translation changes what is treated as legitimate. I have lived two very different professional lives. One was institutional, university training, peer review, clinical discipline, neuropharmacology, regulatory logic, and the other unfolded in parallel. It unfolded in the underground, in an ecosystem that emerged because institutional access did not exist. And I want to be honest about something that is sort of uncomfortable to say in a regulatory setting. For a large part of my life, I believed I was on the right side of history and the law was wrong. Not just inconvenient or outdated, but wrong. I came of age in the late 60s and early 70s. I marched against the Vietnam War. I trained in civil disobedience with the Quakers, and I absorbed the ethics of moral resistance long before I absorbed the language of regulatory science. And at the same time, I watched drug laws expand. We now know through documented historical admissions that drug enforcement strategies were used to target minority communities and to discredit opposition to the war in Vietnam. When I encountered cannabis and psychedelics, I did not interpret their criminalization as neutral public health policy. I interpreted it as political suppression. And that framing shaped me, and it shaped the entire generation. And it's one of the reasons that what looked like drug trafficking from the outside often felt like civil disobedience from the inside. And I believe that moral psychology matters a great deal because it is part of the DNA of the cannabis and psychedelic ecosystems that we're regulating today. Again, the central theme of this talk is conditional access, but I want to say it personally before I say it academically. In the 70s and 80s, access was conditional on trust, on secrecy, on being introduced by the right person, on having the right reputation, on knowing how to behave, or on understanding instinctively that there were invisible rules everywhere. And in that world, there was a paradox. Access could feel more human than it does today because the gatekeepers weren't institutions. They were communities, and those communities had a philosophy. I was heavily influenced by the circle around a famous psychedelic chemist, Dr. Alexander Shulgin. Shulgin was a chemist of extraordinary brilliance, but what shaped me was not only his chemistry, it was the moral seriousness of the people around him. There were chemists, therapists, physicians, artists, and seekers who believed these substances belonged to humanity. They believed the state had no moral right to monopolize consciousness. And some of them believed sincerely and intensely that psychedelic chemistry and distribution had a noble purpose. The language could become almost religious. It was a language of mission, of service, and of liberation. And I absorbed more of that worldview than I realized at the time. I want to be honest about that because it reframed lawbreaking as civil disobedience, and it reframed risk as sacrifice, and it reframed clandestine work as moral courage. And it's one of the reasons so many people from the 60s and 70s were willing to risk everything. They didn't experience themselves as traffickers. They experienced themselves as messengers. Now let me describe what prohibition actually does. Prohibition does not eliminate governance. It displaces it. And what emerges is not chaos. It's parallel governance. There was lawlessness, yes, but the lawlessness was not random. It was a parallel legal system. It had standards, it had reputational systems, it had quality control, it had enforcement, it had punishments, and over time, it developed infrastructure, cross-border logistics, distribution hierarchies, security protocols, money laundering. You can call that cartel infrastructure, and in many regions, that's exactly what it became. But I want to be clear, cartels did not emerge because drugs exist. They emerged because prohibition created a black market premium large enough to support industrial scale organization. And that's not a kind of praise, it's causality. If you outlaw something millions of people want, someone will build a system to provide it. The question is not whether the system will exist. The question is whether it will be accountable. And prohibition ensured that it would not be. As scale increased, the moral clarity of civil disobedience blurred. Money changes ecosystems. Power changes ecosystems. Cross-border logistics introduced actors who are not motivated by liberation or public health. And many of us did not fully grasp how quickly the language of conscience could coexist with the machinery of enterprise. Civil disobedience and organized crime are not the same thing, but prohibition blurs that boundary. Parallel systems often begin with conscience and they end with power. And that is one reason why I care so much about the present moment, because we're watching a different transition now from parallel governance into institutional governance. And institutional governance also has risks. This is an uncomfortable truth for many people, but it's important. Even under prohibition, certain parts of the underground evolved towards something that looked like micro-pharmaceutical practice. You saw SOPs, you saw analytical purity, you saw reproducibility, and you saw process control. Why? Because once you scale, inconsistency becomes expensive. And once you scale, mistakes become dangerous. So the question for regulators is not whether these systems exist, they exist. The question is, how do we pull the legitimate parts of them into the legal sphere without importing the worst parts of Prohibition era governance along with them? When rescheduling occurs, four things happen quickly. First, research expands. Universities, hospitals, and contract research organizations can work more freely. Second, manufacturing discipline increases. Even if a product is still sold through state programs, the cultural expectation shifts toward GMP language. Third, FDA becomes central. Even if FDA is not actively regulating every state program, the gravitational pull of FDA standards increases. And fourth, commercial acceleration intensifies dramatically. Companies rush to file patents, build clinical dossiers, and establish what I would call first mover standards. This is the moment when norms are set. And it's also the moment when enclosure becomes most likely. Now, I want to say one thing bluntly. Cannabis is about to become legal and unaffordable. For most of the people who fought for cannabis legalization, the goal was never abstract policy reform. It was access. Access to a plant that relieved pain, reduced seizures, eased anxiety, restored sleep, and made life more livable for millions of people who were otherwise ignored, dismissed, or criminalized, and whom the pharmaceutical industry didn't address. And here's what regulators need to hear. Legality does not automatically mean access. In fact, history suggests the moment of legitimacy is often the moment access begins to narrow. Not through conspiracy, not through malice, but through routine process, through paperwork, through legitimacy. Because when a plant becomes medicine in the eyes of regulators, it doesn't simply get validated, it gets translated. In that translation, control quietly changes hands. Cannabis itself cannot be patented, but modern pharmaceutical systems don't need to own the plant to own access to it. They only need to own a version of it, a standardized preparation, a specific ratio, a full spectrum formulation approved for a particular medical condition. Once that happens, the real medicine is no longer the plant you recognize. It's the one that carries official permission. Everything else becomes second class, informal, unscientific, unsafe, not because it is unsafe, but because it lacks official blessing. And this is how access quietly narrows even as legality expands. And I want to say this also as bluntly as I can. A plant that grows in the ground should not cost tens of thousands of dollars a year to access. Medicalization that replaces jail with gatekeeping is not liberation. So my argument is not anti-medicine. My argument is legitimacy must be designed so it does not become captivity. I want to use Epidiolecs as a teaching example, not as a criticism. Most people are familiar with Epidiolecs as one of the first cannabis formulations that was approved by the FDA. Long before Epidiolecs was approved, families were already using cannabis extract to treat children with severe epilepsy. And these weren't fringe experiments. Parents watched seizures stop and they documented results. They shared information because no one else would help them. Cannabis was doing something real long before it was respectable. Then Epidiolecs arrived, a cannabis-derived drug approved by the FDA. On paper, this was a victory. Science had caught up. Legitimacy had arrived. But something changed. Epidiolecs entered the market with a list price exceeding $30,000 a year. Access became dependent on insurance coverage and bureaucratic approval. Non-pharmaceutical cannabis treatments, even when they had worked, were suddenly treated as second class. Legitimacy had moved behind a gate, and nothing about CBD and THC themselves changed when Epidiolecs was approved. What changed was who controlled it. And that story is significant because it is now repeating, this time with WholePlant cannabis. I want to be careful here because the science is often discussed in ideological terms. Cannabis contains major cannabinoids, minor cannabinoids, terpenes, flavonoids, and other constituents. There's a long-standing hypothesis that full-spectrum formulations may produce different therapeutic outcomes than isolated compounds. The evidence is mixed. Some studies support synergy hypotheses. Other mechanistic work finds limited evidence for terpene modulation at cannabinoid receptors. My position is simple. We should treat full-spectrum claims as hypotheses, and we should build the empirical program capable of resolving them. And that is what regulators should want. Not marketing and not ideology, but evidence. Here is what cannot be ignored. Cannabis culture has produced literacy. Patients are not blank slates waiting for instructions. They are already experts in their own bodies. They already understand onset curves. They already understand dosing strategies. They already self-titrate. That reality is going to collide with a system built to control access and not empower users. There's a misconception that FDA cannot approve complex botanicals. FDA explicitly describes botanical drugs and has approved multiple botanical NDAs and at least one botanical biologic. The lesson is botanical complexity is not a barrier to approval. It's a challenge of identity, consistency, and CMC rigor. Clinical evidence, cannabis can be made approvable. The question is whether it will be made approvable in a way that creates a public commons or a private monopoly. Enclosure happens through mechanisms that are often invisible to the public. It happens through patents on formulations. It happens through patents on delivery systems. It happens through proprietary standards embedded in clinical guidelines. It happens through data exclusivity, and it happens through reimbursement rules. But the most powerful mechanism is this. A standardized product becomes the default reference. Once that happens, everyone else must compete against the default. And that's how markets become concentrated. And this is not unique to cannabis. It's how medical markets behave. One of the most underappreciated enclosure mechanisms is delivery technology. Companies often cannot patent a plant, but they can patent how that plant is delivered. They can patent stabilization. They can patent excipient systems. They can patent release kinetics. So even if whole plant cannabis remains theoretically open, access can become fenced by proprietary delivery platforms. That is why any public interest strategy has to include delivery formats and not just extract chemistry. In January 2026, I prepared a detailed proposal for what I called a public domain whole plant cannabis medicines program. The core deliverable is a public domain whole plant cannabis extract standard called WPCE-01. WPCE-01 is paired with 3 clinically suitable delivery platforms: an orally disintegrating tablet, an oral thin film, and an enteric capsule. The program includes analytical fingerprinting, stability specifications, GMP-aligned manufacturing, human pharmacokinetics bridging, and staged clinical trials. In other words, FDA-grade discipline, but designed as a shared infrastructure. The intellectual property strategy is crucial. My proposal argues for using the patent system as a shield. This means defensive publication, public interest patenting limited to interface protected inventions, and standardized non-exclusive licensing terms. The objective is to reduce the ability of any single commercial entity to acquire durable freedom to operate advantages during the initial period of regulatory transition. I don't see this as anti-business. I see this as pro-infrastructure. It allows competition to happen on top of a shared standard instead of competition happening through capture of the standard itself. The governance structure matters as much as the science. The sponsoring organization is proposed as transparent, with funding sources, expenditures, protocols, and licensing terms intended to be public and auditable. And this is not just idealism, it's practical, because transparency is one of the few tools that can prevent quiet capture. And in this field, quiet capture is the default risk. Now, I want to shift to what many operators and stakeholders still do not understand, what Schedule 3 actually means. Schedule 3 changes the federal posture in several ways. It changes research access. It changes tax dynamics, including the famous 280E issue. It changes how institutions view cannabis, and it increases the gravitational pull of FDA expectations for quality and evidence, even for products that remain outside the NDA pathway. In other words, Schedule 3 is not simply a loosening, it's a reconfiguration. And the reconfiguration pushes the field towards medical and pharmaceutical logic. It's equally important to understand what Schedule 3 does not do. Schedule 3 does not equal full legalization. It does not remove DEA oversight. It does not automatically create interstate commerce. And it does not automatically create medical reimbursement. Many operators hear Schedule 3 and assume the federal government is about to bless the entire state market. And this is not what it means. What it means is that the system is shifting toward a medical and pharmaceutical framework, whether the market is ready or not. Up to this point, I've described Schedule 3 as a reconfiguration, not a resolution. So let me suggest something more structural. There is an argument, and it's increasingly difficult to ignore, that the most coherent regulatory path forward is not rescheduling. It's descheduling completely. Remove cannabis from the Controlled Substances Act. Regulate it federally in a manner analogous to alcohol or tobacco. Preserve state-level medical frameworks. Maintain quality, labeling, age restrictions, contamination standards, and enforcement against fraud. But eliminate the federal-state contradiction entirely. Why would this make sense? Because we already know something important. Informal networks persist despite attempts at strict regulation. We saw it under prohibition. We have seen it under Schedule 1. We saw it in the rise of dispensaries. We saw it in the persistence of gray markets, even in fully legal states. And the lesson is this: when regulation attempts to over-constrain a culturally embedded substance with massive demand, parallel systems reappear. Rescheduling may reduce friction, but it does not eliminate the structural contradiction. Descheduling would, let me be clear, descheduling does not mean deregulation. It means shifting cannabis out of the controlled substance criminal paradigm and into a consumer protection paradigm. Quality standards remain, testing remains, labeling remains, enforcement against contamination and fraud remains, but access would no longer be mediated by federal criminal classification. Now I want to say something that matters, I think, in this room, and that descheduling is often misunderstood. Some people hear it and imagine chaos, but descheduling does not mean no rules. It means the rules shift. Under a descheduling model, there is still a substantial federal role. There are still product safety standards. There are still contaminant thresholds. There are still labeling requirements. There are still age restrictions. There are still advertising controls. And there are still enforcement mechanisms for fraud, mislabeling, contamination, and unsafe claims. The difference is that cannabis is no longer governed primarily as a criminal substance. It becomes governed as a regulated consumer and medical product with multiple pathways. And in that world, pharmaceutical development still remains fully possible. It becomes optional, not compulsory. If a company can truly develop a truly superior cannabis-derived medicine, something more stable, more bioavailable, more precisely dosed, more clinically validated, it will succeed. But it will succeed because it delivers genuine added value, not because it owns the gate. Pharmaceutical innovation should compete with what is already working in dispensaries. It should not replace it by force of scheduling status. That is a fundamentally different regulatory posture. For farmers, Schedule 3 increases the pressure towards standardization and compliance. Even if cultivation remains state regulated, downstream buyers will increasingly demand stability data, pesticide control, microbial control, and traceable supply chains. That increases costs, and when costs increase, consolidation risk increases. This is one of the biggest structural dangers for small farmers. Not enforcement, but compliance economics. And this is where well-intended regulation can unintentionally favor large actors. For manufacturers, Schedule 3 increases what I call GMP language creep. Even if the product is not an FDA-approved drug, the culture shifts toward documentation, validation, and stability. Manufacturers who already operate like disciplined pharmaceutical organizations will have an advantage. Manufacturers who are improvisational will struggle. This is not moral, it's structural. And it's one reason why the markets will likely split into two segments: a regulated medical segment and a consumer wellness segment. The question is how those segments interact and whether one is allowed to swallow the other. For dispensaries, the long-term risk is displacement. If cannabis becomes medically normalized and if standardized products become prescribable, dispensaries may face competition from medical channels, including pharmacies. The dispensary model may remain for adult use, but the medical market may shift toward prescription and reimbursement structures. And once reimbursement becomes involved, access becomes conditional on insurance rules. Now, I want to state the contradiction as clearly as I can. The dispensary system evolved into something very American. It became, in effect, a retail pharmacy for the unmet needs of modern medicine. People sought relief for pain, anxiety, insomnia, PTSD, epilepsy, nausea, inflammation, and countless other conditions that conventional medicine either failed to address or addressed too expensively, too slowly, or too indifferently. And this is why dispensaries became de facto pharmacies. Now rescheduling arrives, and suddenly the system wants to pretend those two functions were always separable. The idea seems to be recreational cannabis stays retail. Medical cannabis gets pulled back into the federal pharmaceutical apparatus. But these are not adjacent business models. They are opposites. And patients are not blank slates. They already know what works. You cannot uninvent lived experience. So the collision is coming. One of the most complex parts of this transition is cultural. Cannabis and psychedelics emerged in modern America through countercultural systems, systems where ritual and community were central. Medicine requires protocol, documentation, reproducibility, controlled access. So translation is not just scientific, it's cultural. It is the conversion of informal trust into formal compliance. And when the conversion happens too aggressively, it can destroy the very communities that carried these medicines through prohibition. The best translation is not extractive, it's collaborative. It respects lived knowledge while applying rigorous standards. This is the slide I think is most important to remember. Legitimacy can become captivity. Medicine becomes legitimate. Then access becomes controlled. Then pricing increases. Then indications narrow. Then gatekeeping becomes formal. And what was once widely accessible becomes accessible only to the insured, the wealthy, or the clinically approved. It's not conspiratorial. It's a predictable system behavior when standards become property. So the design of public interest infrastructure is not optional. It's a safety strategy. Regulators are often framed as enforcers. But in this transition, regulators are system designers. You protect safety, you protect evidence, you protect quality, and whether explicitly or implicitly, you protect public interest access. And you do this by deciding what counts as legitimate evidence and what counts as adequate quality and what kind of claims are allowed and what kind of market behavior is rewarded or punished. Standards determine who can participate, and participation determines what kind of field we end up with. AFDO in particular has influence. AFDO helps shape model policies and helps harmonize language across states. AFDO educates officials, and this is significant because inconsistent regulation creates loopholes that are exploited by bad actors, while overly aggressive regulation can unintentionally create monopolies by making compliance unaffordable. So the regulatory task here is delicate. It requires discipline, and it requires humility, and it requires safety standards that are real, and it requires attention to how those standards reshape the market. I want to give you some perspective on this from the psychedelic industry. This is the design choice. Public infrastructure means open standards, shared evidence, and non-exclusive licensing and affordability. Private silos mean proprietary standards, exclusive dossiers, patented delivery fences, and high-cost access. And I want to be clear, private companies will always play a role. They often drive innovation. But if the foundational standards become private, then the field becomes captive. So the public interest goal is not to eliminate private development. It is to ensure that the foundational commons remains open. And we have a clean precedent for this in the psychedelic space. The Usona Institute faced a crossroads with psilocybin. Psilocybin is naturally occurring. It has a deep cultural history, and it has enormous therapeutic promise. Once research barriers fell, it was obvious that companies would rush to fence it. Usona chose a different path. Rather than trying to own the molecule, they deliberately placed key information into the public domain. They conducted serious FDA-grade clinical trials, but they kept the underlying substance from being monopolized. That decision really mattered. By publishing foundational knowledge early, how psilocybin is made, how it is standardized, how it is studied, Usona made it far harder for anyone to claim they had invented it. Legitimacy was achieved and science moved forward, and now no single company owns the foundation. Cannabis is at the same moment, but the stakes are even larger. Cannabis serves millions of people, not thousands. If whole plant cannabis becomes enclosed behind prescription walls, the consequences will ripple outward for decades. So this is the core question. How do we achieve scientific legitimacy without enclosure? How do we create FDA-grade evidence without creating commercial monopolies? And how do we create safe, standardized medicine without excluding the public? And how do we allow innovation without allowing capture? My position is straightforward. Rigor is non-negotiable. Evidence is essential. Safety is essential. But access should not require captivity. If we want whole plant cannabis medicine to remain a public good, we have to design the commons early, before the market hardens. And that's why I wrote the public domain proposal now at the moment when rescheduling appears imminent, because the transition window is very short. And once the default standards are set, it becomes very difficult to reopen the question. So in closing, I just want to say access is always conditional. The question really is conditional on what? Conditional on secrecy and parallel systems, conditional on exclusive patents and reimbursement gatekeeping, or conditional on transparent standards, shared evidence, and public interest governance. I believe we have a rare opportunity to design legitimacy without captivity, and I appreciate the AFDO and the regulatory community for being willing to have that conversation. Thank you. I look forward to any questions.
Thank you so much, Dr. Potter. What an amazing presentation. And, it's so important to have these difficult conversations and ask the difficult questions, especially as we are at that point, at that precipice where, there's a possibility of rescheduling, or if we can push it through the finish line, descheduling, which, a lot of us are rooting for. And thank you again for helping clarify really what Schedule 3 means, because a lot of times, I've spoken to a lot of different operators in the industry, and they don't fully understand what Schedule 3 actually means. All they care about is, hey, 280E. That's what they care about, but they don't understand that it's basically we're going to lose a lot of different operations. We're going to lose a lot of different products. We're going to lose a lot of small operators, and very, very likely lose various cultivars and varietals for whole plant medicine that is being not only cultivated, but also various products that are out there. So, it's definitely a question that we need to have. But before we get into the questions, I just want to have some housekeeping again, just to invite everybody for our next session. It's going to be on February 25th and March 13th. It's a two-part series with Dr. John McKay. He will be discussing principles and practice in assessing compliance in cannabis manufacturing. So bring your questions about everything from extraction to purification and refinement and manufacturing. He will, make it so that it's very easy to digest, because I know there's a lot of information out there, but it might not be information that is easy for us to adopt or even understand. So please join us for the next session. And for the next slide, Amy. And for those of you who don't already join our AFDO Cannabis, Hemp, and Natural Psychedelics Committee, you can join us by clicking on the website or scanning the QR code. And regarding Dr. Potter, if you have specific questions for him that we don't answer during the webinar, or if you're trying to get in touch with him, please feel free to go ahead and reach out to me. I am his point person and will be filtering, information to him through everybody else so that he can focus on the very important work. So, Dr. Potter, Kelly Ripple asks, what is your expectation for states like cannabis with zero tolerance for if rescheduling happens versus descheduling?
Let me understand the question. I think if we're talking about descheduling, that's one conversation. If we're talking about rescheduling to Schedule 3, that is definitely another conversation.
Yeah.
I mean, from my perspective, the one thing that kind of shakes out in a pretty direct fashion is that we already have existing state infrastructure, and that existing state infrastructure is pretty well embedded at this point. And I think Schedule 3 may be a misnomer kind of classification. Again, I feel like if pharmaceutical industry is able to provide real value added, then a case can be made for a value added cannabis pharmaceutical. But unless it adds some level of stabilization, bioavailability, increased efficacy or safety, I don't see why consumers or / patients should be asked to switch to that model.
The next question is, presuming medical capture, do you see any hope with Mark Cuban's cost plus drugs approach, or is it the company subject to waiting for generic availability? Is that company subject to waiting for generic availability?
Yeah, so Mark Cuban's pretty downstream from the regulatory process. What my concern is how actual public domain research gets stifled by proprietary capture. And that happens pretty much upstream of what Mark Cuban proposes. Yeah, it's great to get cheaper drugs, but I think what we really need to do is look at the way Epidiolex as a model captured research for a long time. But as soon as you said, THC and CBD are together in a formulation, then suddenly that precedent really restricted the kinds of formulations that were available. And so I think, we really have to think seriously about upstream how we navigate this regulatory issue of public domain versus proprietary ownership of the compounds. And I'm not saying that private enterprise doesn't incentivize innovation. I'm saying that innovation can take place on top of a public commons ownership, and I think ultimately that'll end up encouraging research and development.
I mean, you and I have spoken a lot about, not only what Schedule 3 means, but, trying to protect the whole plant, trying to protect the various cultivars that are out there, trying to protect access to those who really need it. Because, and I understand your point of view where, we have to assume that any sort of medical results from whole plant medicine, that should be a hypothesis, right? There, we have we can find proof, evidence, whether it works or not, both ways. And so, we've discussed a lot about ensuring that the various cultivars that have different cannabinoid profiles, different terpene profiles, various attributes to the plant, and we need the time in order to research it. And so with the descheduling, that still allows for that as well. And it protects, the various cultivars that are out there, because there's so much that we don't know. And where are we, and as in the United States, where are we in terms of, research in the cannabis space with respect to other countries?
That's a really good point. I did see somebody come through with a question saying, how do we sign on to a program to ensure public domain access to the whole plant and research on the whole plant? I just put forward a proposal. We're at the point now of seeing if we can develop a sponsoring organization that contains that proposal and use that proposal as a model for governance. And the way I see it, we have this precedent of USONA, and I'll just describe it one more time. Compass Pathways came along and created a version of psilocybin called Comp 360 and immediately began clinical trials for depression with Comp 360. USONA Institute, a nonprofit, wasn't having it. They said, psilocybin's been around forever. Let's see if we can advance psilocybin with GMP standards. And they used a colleague of mine, Dr. Alexander Sherwood, as a medicinal chemist who developed the GMP standards and a route to making psilocybin available very inexpensively, and began to offer it to people to do research in the area, and then began their own clinical trials on depression. So now we have these two competing, enterprises, one proprietary saying, we're going to charge a lot of money to treat your depression, and another saying, we're going to try and make treating depression as inexpensive as we possibly can, given the prior art, the priority of psilocybin in the public domain. So that's essentially, what the proposition is, and we're just now at the point of trying to put together a sponsoring organization as rapidly as possible to ensure cannabis doesn't go completely in the proprietary direction. And there are companies, a number of commercial companies, that are already targeting whole plant formulations of cannabis that are intending to capture it exactly in the way I described. And once they do, that's prior art, that's patents, that's FDA regulatory runway, and then we all have to work around that.
Sure. And Dr. Potter, for those who are still new to the space, can you explain how a company can patent a plant that per harvest, it might have a very different cannabinoid profile or a different terpene profile? There's usually ranges if it's one specific strain, but how can a company patent that?
The FDA works with ranges. They're willing to say, this botanical extract has active principles that fall within these ranges. And that's usually the way it's defined. How those, where the boundaries are for what those ranges are to be determined. But the FDA has a process, an existing process for having done that. And we have botanical extracts, and it's a matter of trying to define to the greatest degree possible all the constituents of that extract and having them adhere to a standard. So the process already exists within the FDA, and I think I want to propose, let's work with those standards. Let's work with that precedent, only let's capture it for the public domain instead of for the proprietary domain.
Absolutely. So to kind of discuss that a little bit further, I know that over in the EU, they have the seeds registered, the genetics registered. Now, how would that play into, let's just say, a Schedule 3 framework in the United States? and the patenting of, these various whole plant extracts.
So my understanding, genetics can be patented, but when we start making an extract, that becomes, another commodity, and it itself can be recognized through patenting, and the FDA. Yeah, one of the things I want to mention though is delivery technology, because formulation and delivery becomes a vehicle for getting a new drug approved while retaining the generic quality of the original API. So in other words, we take, a generic API, we deliver it in a very unique way, whether it's through an orally dissolving tablet, an enteric delivery that promises greater bioavailability, and we have biomarkers that we can measure that and put that case forward. Then that becomes essentially a new drug, and it allows us to, you know, sort of set the boundaries in the public domain and say, hey, look, these formulations are already exist in the public domain. I propose trying to file that as broadly as possible with what I would describe generally as pre-gastric delivery. Once we start digesting cannabis, we have metabolites, we have a range of different things happening, that it's much easier to supervise if we can stick to the pre-gastric delivery forms. And those can be patented. And the FDA recognizes those as new drugs in the 505(b)(2) path. And they'll allow a regulatory exclusivity for several years for that. So, I think, that's the strategy that I think might work here.
Okay, so let's go down the pathway of Schedule 3, if it indeed goes down that pathway. And I know that you briefly discussed what the implications would be for farmers and manufacturers, and even dispensaries. So would all of these operators have to obtain a DEA license in order to cultivate, manufacture, and sell these commodities if we did go through with Schedule 3, with rescheduling?
It's hard to imagine, the pharmaceutical industry capturing every last cannabis product. It's a bit hard for me to imagine that, given how embedded the state distribution systems are. So I think what will happen is, there will be some attempt to draw a line and say, these are pharmaceutical products, these are recreational or adult use products, and they'll try to kind of divide it up that way, which I don't think is really going to work, because there's so much crossover already. So that's where Schedule 3 becomes extremely unwieldy. So you're going to say, oh, this CBN preparation that works for sleep, that's a pharmaceutical now. Well, I've been buying it as over a recreational counter for this whole period of time. Now I'm going to have to, pay pharmaceutical prices to get it. Doesn't seem to be something that will be an easy transition. Again, I'm all for pharmaceutical innovation. Can you provide something that works better than what we have now? Sure, reward that innovation. But to just say, we're going to turn this into a pharmaceutical drug, no, I don't think I don't think that's going to be workable. You already have like I said, a major industry. You have multi-state operators. You have, dispensaries in so many states. I just, and I'm going to say one thing very quickly. I think the problem is, the only framework we had for cannabis was as an intoxicant. We decided that it was, a regulatory framework not dissimilar from alcohol. So we created kind of a hybrid structure. And now we're going to come along and say, well, there's a carve out for its medical aspects, and we're going to regulate that differently. Well, we really have to see the extent to which that, limits patient access and limits access for consumers.
Yeah, I agree. I agree. Um, so regarding Schedule 3 for a manufacturer, and I understand and respect everything that you're saying, but if it did come down to, because I know a lot of manufacturers are preparing for Schedule 3, they are, and a lot of manufacturers already operate with good manufacturing practices. A lot of them have obtained their certification for CGMP, and they're preparing for this. If it got to the point where every single manufacturer had to meet the requirement and the standards for Schedule 3, what else would they have to do? And I know that we spoke briefly on, monographs. We spoke briefly on what the implications of Schedule 3 would be. But if you can elaborate that a little bit more, and how would that impact the regulatory community with respect to how they conduct inspections? Because right now the boots on the ground are local and state regulators.
Yeah, we have a lot of experience through the FDA and at the federal level with CGMP standards as the standards for pharmaceutical manufacturing. And that's the default regulatory standard. Labs have to be adhere to ISO standards. So I don't think FDA is going to want to reinvent the wheel here. I think that CGMP will end up being the default standards. ISO will continue to be the standards for labs. And at the end of the day, yeah, GMP can be onerous for manufacturers in transition. But at the end of the day, it's a lot of documentation. It's a lot of, chain of custody, a lot of being able to ensure product safety. And, I think that there may be a gravitational pull towards CGMP standards as the standards. I don't see how we're going to say, okay, we're going to have slightly relaxed GMP standards. The good news is that many of the state standards that already exist for manufacturing are awfully close to GMP already, just because that's what commercial enterprise demands. You have to be able, if something goes wrong with the product, you have to be able to determine what batch it came from. And, you have to test regularly. So I think that we're already operating in that environment in the States. So it's not going to be, a tremendous lift, increased sterility, increased, attention to detail in terms of, contamination. But I don't think it's going to be a lot, honestly.
Well, that's great news. Um, so I wanted to kind of pivot a little bit from the manufacturing perspective over to the testing side of it. So again, assuming that we go down the path of Schedule 3 rescheduling, there are a lot of independent laboratories in various states, and because there's no interstate commerce or sending of products from one state to another to get tested specifically for cannabis, how do you foresee that impacting the laboratory testing industry?
Yeah, I've always felt that the testing was a real example of chaos, where every lab has their own analytical standards. It creates an environment or a landscape where people shop for a certain kind of COA, whatever, however it benefits them. And I think, California, Colorado made a big mistake in not just having a state lab with analytical standards that were across the board, that everybody could just say, look, this is what the standards are, and you don't have this chaos that we have now. And so I would extend that to interstate and say, maybe that's a place where the federal government can say, okay, these are what the analytical standards are. This is where we can do some good, because right now you can't tell whether or not something is being, what the motivation is behind a particular COA.
Yeah. Yeah, I absolutely agree with that. And, and there are a lot of laboratories that, um, you know, I'm going to say, I guess from the state perspective, there are several states that I've looked into that don't necessarily have the expertise or even, the workforce to audit and inspect these laboratories. So I definitely applaud the states that do have the capability of doing that. But, having audited several laboratories myself and seeing the, you know, not only inconsistency, but also the deficiency, it makes me concerned when, we're relying so heavily, on the testing community, the laboratory community, to provide a transparent certificate of analysis for the various products.
So
Um,
instead of empowering this, regulatory enforcement that has to go out and audit labs, one central standard, one central, I mean, ideally, it would all be submitted to one state lab, and we could just relax and be assured that the COA we're getting was conducted according to ISO standards, was conducted properly, and there's no, oh my gosh, is this the latest COA? And the divergence is like pretty dramatic, I think, from what I've seen.
yeah, yeah, it surely is. And even from the laboratory perspective, my understanding is that they also have to obtain a DEA registration for the laboratory to accept those standards. And so that's, just another hurdle that the industry has to overcome. So it makes it a little bit more difficult as well. Um,
The DEA will be involved, no matter what level of Schedule 3 we see.
mhm,
DEA is going to require registration. You know, they register over the counter drugs. There will be some accountability to the DEA, but they do have their hands full trying to
mhm,
control the amount of fentanyl that we have in the country.
yeah.
And nobody is giving anybody a letter of commendation for, for cannabis, for busting, cannabis users, or, it's just not, it's frowned upon in some ways. They have a mandate. Maybe this will allow them to focus on what that mandate is and have the registration be as minimal as possible and their involvement as minimal as possible.
Hmm. Hmm. Yeah, yeah. Um, and so let's talk about, because we don't have a lot of open questions right now, but there are a few questions that, I've had other operators and stakeholders ask me who are unable to join the webinar. But do you foresee, if we were able to make that push for descheduling, if we were able to all come together, and I'm speaking to attendees as well, because it takes all of us to raise our voices and demand what we actually want out there. If we did go down descheduling, very similar to hemp, do you foresee that there's a possibility that for the states that have two separate programs, hemp program, because hemp is regulated differently than cannabis, do you foresee that we would be able to integrate a a standard, a national or even federal framework that would make it that much easier for the states to regulate and for the federal government to regulate, because
Well, let's be
that's
clear. If we move to Schedule 3, FDA influence will increase. There, that's just going to happen. Uh, but the inevitability of how that plays out still depends on design choices. Uh, Again, as we said, the FDA has botanical pathways. They define botanicals in specific ways. The FDA does not require monopoly ownership. So I feel like if early on stakeholders can build early public domain standards, the agency can regulate those standards without privatizing them. So I don't know that inevitability is the right frame here. Momentum is the right frame. Public sentiment is the right frame for this. And I think we can have tremendous influence. No question the FDA is going to be more involved, but I think we should, target how we can uh, ensure that, hemp remains accessible and the how we define it is reasonable. And we're going to have to do that through the FDA if it's Schedule 3.
Mhm. Mhm. I think a lot of states are wanting more involvement from the FDA. So that would be a good thing for sure. So we do have some comments in the chat. It's not a specific question, but there's questions as to how people can be involved in this commons project that we are working on. I'm going to let you kind of just, it's very new. We're still putting everything together right now, but Dr. Potter, if you would like to elaborate a little bit further, and then we can make sure that we can get that information out to people to participate.
Yeah, the way I'd see it, I mean, right now we've got to funnel it through you, Twee. So, if people have interest or questions, please use Twee as kind of the point person. But we are at the point, I put together the proposal. It's on my Substack. I could probably put, my Substack address in here and the link to the proposal so people can read it. And a couple other articles I've written in my Substack on, uh, you know, cannabis is about to become legal and unaffordable, and on rescheduling. That I've written a few pieces on that. And you kind of see where my thinking is. But the kind of organization I envision is a democratically governed organization that's extremely transparent with everything is auditable, where we make decisions about trying to keep cannabis whole plant formulation in the public domain. And I'm willing to lend my expertise to this. It may actually result in, uh, you know, having to develop human clinical trials. And, I've run clinical trials in the past, and I know what it takes to, file a new drug application with the FDA. And I'm quite willing to lend that expertise to the project and try to use that to push this through. But I believe it's kind of an end run. Nobody's really expecting the public to be endowed enough to come in and say, okay, well, we're going to have our own, formulation, and that's going to be foundational, and it's going to represent prior art and FDA exclusivity. It's almost like using the commercial pathways against commercial enterprise. So we're at the point now where, we want to form this organization. We're just in the process of forming it. This talk reflects, my thinking, but it doesn't really have the organization fully developed and codified yet. We're still in the process of doing that. And, I'm just trying to gauge public momentum and, is there interest in doing this? Is there, are there enough people out there who want to join together and see this as a worthwhile cause. We were able to do it in psychedelics. Now psilocybin is safely insured to be something that is accessible for people. So I think we can do the same thing with cannabis. And we're at the point right now of forming that organization. And like I said, I just want this to be, from my perspective, democratic, transparent. The governance is, just open source. And, it's just for the public benefit for once, Let's just try to do something selflessly for once and not make money on it.
Absolutely. I agree with that. Well, thank you so much, Dr. Potter, for your time, and for those of you who would like to, remain in the know about the Commons Project. We are in the very beginning stages of putting everything together. So if you just stay in touch with me, I'll be able to, put out that information as it becomes available. We are literally in talks, putting the organization together right now with all the documentation and filings and whatnot. So please stay tuned for that, and we will give you updates as it progresses. And Dr. Potter, again, thank you so much for your time. Thank you for your expertise. And, we welcome.
I'm gonna take a minute to put my Substack in there. And there's also a pretty interesting monograph I just wrote on psychedelic therapy. It's kind of a comprehensive overview, and that's available to everybody. And let me also see. I'm going to put the specific link to the article on the proposal for public domain WholePlant formulation and a couple of other articles. So you'll be able to find at least, and you can probably communicate with me on Substack if you want to.
Yeah.
Let's see. So that'll just take a second here. Let's see.
Well, thank you so much. And please make sure that you capture this information. And Amy or Steve, will the chat also appear in the recorded webinar? Specifically the links from the chat?
There's a few.
Yeah.
And I should also say, I see this as completely nonpartisan. It's not like I see this as being any kind of a partisan endeavor.
Thank you so much. So for those of you who are unable to click on the Substack links, feel free to reach out to me. We can definitely get that information to you, and we can share the proposal for the Commons Project as well. Thank you again for everyone's time, and we will go ahead and conclude the webinar. Thank you, Dr. Potter.
Thank you. Thank you, everybody.